at least for me personally. Can you see the show now? Yeah, good. So I think I will start a little bit with the anatomy and pathophysiology and introduce you to the different measurements. And then we will discuss about how these patients present, and then we will discuss some surgical principles and some details. And in the end, we will discuss how these patients do, what the outcome of the surgery is. So the cervical spine, as you all know, has a natural lordosis, the alignment, and the degree is usually, or the lordosis is measured between C2 and C7, and it's usually somewhere around 20 degrees. But there's a huge variability. But the lordosis is important for the function of the cervical spine because the anterior load, the axial load is shared between anterior and posterior. And the lordosis is important because naturally or physiologically, 2/3 of the axial load are shared posteriorly and 1/3 is shared anterior. When you do the measurements between healthy or at least asymptomatic subjects, you will notice that there is a large variation. It might be, you might even find patients which are slightly kyphotic, but are asymptomatic. And of course, you only consider treating a cervical deformity if it's becoming symptomatic. You would not treat a slight deformity just to cure the picture. Patients have to be symptomatic. But it's important to realize that 90% of the patients presenting with so-called cervical deformity are patients which are in kyphosis. There is a small subgroup of patients where you might have a hyperlordosis, but the majority of patients that I'm going to discuss are patients which are hyperkyphotic. And usually you would target the cervical deformity either because it's symptomatic alone, but many of these patients are becoming symptomatic with signs of degenerative myelopathy. And then you do the diagnostic workup and you realize that these patients are also in cervical kyphosis. And then you have to discuss whether you will treat only the myelopathy or you will treat the deformity as well. On the right lower, you can also see on the table that these measurements are subject to change when patients become older. And it's interesting to note that physiologically, the lordosis is increasing in elderly patients. And this is because the cervical spine is compensating for the loss of lordosis in the lumbar spine. And with the back becoming more straight and the patient leaning more forward, physiologically the cervical spine becomes more lordotic as a compensation. You would think that they become kyphotic in age, but they don't. They become more lordotic. So the most important angles that you measure are the following. So first of all, you measure the lordosis between C2 and C7, and then you have the T1 slope, which is here. The T1 slope is very similar to the sacral slope, and this already shows you that there are some similarities and some parallels between the cervical alignment and the lumbar pelvic alignment. So T1 slope is analogous to the sacral slope. Then the T1 slope will determine the thoracic inlet. And then you can already see that similar to the lumbar spine, where most of the lumbar lordosis comes from L4 to S1, that is 70%. It's very similar in the cervical spine, where 70% of the cervical lordosis are coming from C0 to C2, from the axial spine. And the subaxial spine, C3 to C7, is responsible for only 1/3 of the cervical lordosis. So there are some parallels between the cervical alignment and the lumbar alignment and how it's organized. The T1 slope might vary under pathological and under physiological situations. So a physiological variation of T1 is that T1 might vary depending on the overall alignment of the patient. And I will show you in another slide. If the patient, for example, has a very pronounced lumbar lordosis or has a high Roussoulis type due to a high PI, pelvic incidence, then the patient will have a pronounced cervical lordosis with a pronounced T1 slope. On the other hand, if the patient is losing his alignment and his balance in the thoracolumbar area, he will tilt forward and the T1 slope will increase, will become more steeper. So the T1 slope can be a readout of loss of overall sagittal balance, or it might be the result of some variations due to the overall sagittal alignment. It's also interesting to note how these what parameters are changing over time in the younger patients to the older patients. And I mentioned that the lumbar lordosis will increase in the older patients, and at the same time you can see how the sacral slope and how the T1 slope is changing with the loss of the lumbar lordosis over the time. So this is increasing in the elderly patients, and at the same time, the SVA might change. So we have heard about, so one way how you can describe the deformity or the lordosis is the angle between, the cup angle between C2 and C7. Then you can also have the vertical line from C2 to C7, which is the C2, C7 plumb line. You will see it in the next slide. But another important parameter that you might measure is the T1 slope minus the lordosis, which is a very good parameter which correlates with pain parameters and with the symptomatology along the cervical spine. So we have the C2, C7, we have the T1, and from there we can calculate T1 slope minus the lordosis, which is a readout of the lordosis of the kyphosis. And here is the plumb line from C2 down, and you measure the distance from the C7 plumb line, which is usually somewhere around 2 centimeters, and it becomes pathological if it's more than 4 centimeters. So 4 and more centimeters is a significant cervical kyphosis with the plumb line of C2 going in front of C7 by more than 4 centimeters. I mentioned T1 slope minus the lordosis. And then you might find in the literature other parameters. I like the C2 slope. The C2 slope, similar to the T1 slope, is increasing when the patient is going into kyphosis. And these are the main parameters that help you to describe and to understand and to measure the extent of the cervical deformity. And this is to remind you that you cannot look at the cervical lordosis or the cervical anatomy in an isolated way. The cervical lordosis is part of the overall sagittal alignment of the spine, and it's heavily affected by the anatomy and by the alignment in the thoracolumbar and lumbar pelvic area. I mentioned that the sacral slope is very similar to the T1 slope, but it's also true that, as you can see here, that sacral slope and pelvic incidence will translate in lumbar lordosis, and the lumbar lordosis and all these spinopelvian parameters will then translate into the anatomy under physiological means of the cervical spine. So it might either be, you might have a steep T1 slope resulting in a pronounced cervical lordosis, and if you have a low Roussoulis type in the lumbar area, then this will result in a not so steep T1, in a shallow T1 or low T1, and in a less pronounced cervical lordosis. So this is how we always have to look at the whole spine, and this is why whole spine imaging is also important, and we'll come to that later, if you are trying to understand cervical lordosis and if you're aiming at correcting cervical deformities, and if you're aiming at correcting the cervical deformities. So always look at the whole spine. So what are the consequences if a patient is developing cervical deformity? What's going to happen? First, by the anatomy. So if the cervical spine goes into kyphosis, this means a forward shift of the cervical alignment, and this will contribute to a sagittal imbalance. The spine can get out of imbalance either because loss of lordosis in the lumbar area, but the same is true for cervical kyphosis. And in the end, the head moves forward and is going out of the center of gravity. And similar to the lumbar area, this might create pain because you have fatigue and more stress on the muscles of the cervical spine. But also this might result in damage to the spinal cord, which is unique to the cervical area in contrast to the lumbar area. And another unique thing is that your horizontal gaze might change. The patients start to look on the floor, and to some extent they can compensate by mechanisms I'm going to discuss. But in the end, the further the head is going in front of the gravity line, the more the patient will look on the floor, and the gaze of the head and how the gaze of the patient is really a main driver of the different compensatory mechanisms along the whole spine. And furthermore, once the patient is getting into cervical deformity or cervical kyphosis, it's very likely that this is going to progress over the years. So the most frequent symptoms are, number one, pain and loss of quality of life. You can see here a paper that is correlating the pain scores like NDI with the cervical lordosis, with the T1 slope, and with the T1 minus cervical lordosis parameter, and they all correlate. The more pathological they are, the more pain the patient is experiencing, and the more his quality of life is decreasing. Another paper showing that the more the SVA, so the plumb line of C2 versus C7, the distance, the more the patient is getting into kyphosis, the more pain the patient is developing and reporting, and the more quality of life parameters are deteriorating. So it's really, again, similar to the lumbar area. The more deformity, the more pain, and the less quality of life. So this is really affecting quality of life as well, even without neurological deficits. I mentioned the consequence of the gaze. So even if you fix patients in a too kyphotic or only straight position, patients might end up with a pathological gaze. You all know the relevance of the gaze if you are fusing around the axial spine, but if you are not correcting the subaxial spine, this might also result in a gaze that is going down to the floor. And the patient will try to compensate for that. If the cervical spine is fixed and the gaze is fixed, the patient might increase his lumbar lordosis and have a forward tilt of the pelvis. And similarly, you can think of other situations where the gaze is really driving the compensatory mechanisms of the still mobile spine, and this might lead to additional problems if it remains unrecognized and untreated. So cervical deformity will result in a disturbed gaze, and this is quantified by the chin brow to vertical angle, or CBVA. Here is a paper that nicely shows another compensatory mechanism for the cervical spine. So it's interesting to note that the axial and the subaxial spine and the alignment of C0 to C2 versus the alignment of C3 to C7 are heavily correlating to each other. In other words, if the cervical spine becomes kyphotic or straight from C3 to C7, maybe due to degeneration, the lordosis from C0 to C2 will increase. And if the patient is going into kyphosis, the patient will try to compensate by elevating the head just to keep the gaze just to keep the horizontal gaze. So it's really important to understand that it's really a dynamic, that the cervical spine is very dynamic, with a strong correlation between these two segments of the cervical spine. Or if the subaxial spine is hyperlordotic, again, C0 to C2 will compensate accordingly. And this is interesting, for example, in this disease entity, we call it a hyperlordotic syndrome of the axial spine. Patients which are in kyphosis at C3 to C7 might compensate with hyperlordosis, and this might lead to formation of a pannus or chronic inflammation. This might also be accompanied with some kind of pannus formation, although this patient had no rheumatoid arthritis. But on the left, you can see that you will identify some bony and ligamentous changes that will then lead to this kind of compression of the higher spinal cord at the cervical medullary junction. And these are two nice examples showing how the axial spine is going into lordosis to compensate for the hyperkyphosis of the subaxial spine. And it's really interesting to think about how you would treat this condition, because if you are taking it seriously, you might have to correct the subaxial spine plus the axial spine and not only decompress at the craniocervical junction. And number three, many of these patients have myelopathy. There are two ways how patients might acquire myelopathy. Number one is they have osteophytes and they have a stenosis in combination with a deformity. Then they obviously have a compression of the spinal cord. But some of the patients might develop myelopathy only by cervical deformity because the spinal cord gets stretched over the kyphotic cervical spine. And this stretching of the spinal cord is already enough to create the state of chronic ischemia and chronic myelopathy. So you don't necessarily need stenosis in order to have myelopathy in the light of cervical deformity. Sometimes a hyperkyphosis is already enough to create spinal cord malfunction and myelopathic symptoms just due to the stretching. And this is nicely shown in this recent publication, where the authors have used some kind of modeling using finite elements, and they have calculated a spine without compression in lordosis in straight 0 degrees and in kyphosis. And the more the spine leaves lordosis and gets into kyphosis, the more you can see the stress on the spinal cord. And this is already enough. You can see the stress is mainly on the posterior element. So you would expect that this patient reasonably might develop some kind of spinal ataxia with pathological SEPs, for example. And if this stretching is then combined with some kind of compression, this is further aggravating the stress on the spinal cord. So this tells us that if we have a patient with myelopathy, it might not be enough only to decompress, but also to correct the deformity and to reduce the stress on the spinal cord. So it's very important to keep that in mind, that you can acquire myelopathy. And this is very traditional neurosurgical thinking. You think myelopathy is also always from compression and from stenosis, but no, you can expect myelopathy also from stretching due to hyperkyphosis. So if you are aiming for surgery, what are the aims? And I think especially with a neurosurgical audience, or at least for me, I have changed my thinking over the last 15 years. Number one, I was taught to operate these patients only if they have neurological deficits. And we were very reluctant to treat patients for pain or for progressive deformity, or if they had programs with their horizontal gaze. But this has obviously changed. Today, we would operate these patients much earlier, maybe also for pain and also for if patients are developing progressive deformity, not necessarily for degenerative disease, but maybe for post-inflammation or post-traumatic deformity, which is increasing. The overall subjects would be to decompress, obviously, to stabilize and fuse, and then to correct the deformity. And I think this is a major point of discussion, and it's still a controversy, how much to correct the deformity. And how do you assess the patient, and what are the treatment objectives? Are we going for neurological recovery? Are we trying to reduce our complications? Are we going for quality of life? Are we including prompts if we are assessing the patients? Or are we saying the patient should be happy that his myelopathy is not progressing? Is our aim to have as little revision rates as possible? Or are we aiming for normalization of the radiograph, of the radiographic parameters, of the angles and measurements that I've shown you? So while we would all agree that the surgical principle when we are treating these patients is to correcting the deformity in some extent and thereby increasing the anterior column and shortening the posterior column, the old debate is, should we aim for a mediocre correction of the deformity, so aim for straight or a little bit lordosis, or should we aim at re-establishing the overall balance and the cervical alignment in a way that it's close to physiological parameters? And I think this is something that has changed over years. I think the classical neurosurgical thinking was to decompress and not overcorrect, just do a little bit of correction. And I think the more biomechanic way thinking that we have adopted, and where we have learned a lot also from our orthopedic colleagues and from the interdisciplinary exchange, is that now we are really aiming at getting a good image result, a good radiographic result, and a good and a satisfying reestablishment of the lordosis. So our decision making for the surgery starts with the understanding what is the driver of the cervical kyphosis. In most cases, the driver of the cervical kyphosis is the cervical segments. So the mid-cervical or the subaxial spine, especially if you have degenerative disease. And then you can identify these cases by a low T1 slope and a high C2 slope. So if you find that combination, the driver of the cervical kyphosis is cervical. But then there are patients where the problem is not in the cervical spine, but the problem is in the subcervical segments, cervicothoracic junction, or thoracic kyphosis, or loss of lumbar lordosis. And you really have to identify these patients, because otherwise you treat the cervical spine and the problem is completely somewhere else. And you can identify those patients that they usually have a high T1 slope because the cervical spine is tilting forward, and then the T1 slope is going down, is increasing, and they have usually a low C1 slope. So this is a rule of thumb. Use these two angles. You might also find other reasons for these combinations, but it's a very good way to start the assessment of your images. And obviously, you should do that in standing X-rays, ideally in whole spine standing X-rays or in EOS imaging. So this is an example where the cervical. So what are the drivers of deformity? So this patient is only in kyphosis because the driver is in the cervicothoracic junction, an old fracture, and this was treated by C1, C2 reposition and fusion with C1 screws and C2 screws, and you can see the intraoperative image, and you can see the relordosing and repositioning and reestablishment of the axial lordosis. So this was the only reason why the patient was in kyphosis, because the driver was the axial spine. The classical driver of the mid cervical driver is usually due to degenerative disease. So what's happening is that you have a loss of height, and you're losing the discs. You're losing the disc height. You get the anterior osteophytes, and the patient is progressing into cervical kyphosis. Then the patient might develop this S-shaped form of his cervical spine, maybe even with a hyperlordosis of the axial spine, and then you might get some ankylosed facets. And here you have a clear, the clear driver of the cervical kyphosis is the cervical spine. So this is the classical case. Here an example, the patient had previous surgery, developed a segmental kyphosis in the mid-cervical spine, and then was treated accordingly with a vertebral body replacement and anterior and posterior fusion, in this case using a combination of pedicle screws and lateral mesh screws. But here, the problem came from the mid-cervical area, and the problem was addressed accordingly. This is a patient where the driver for cervical kyphosis is not the cervical spine, but the cervico-thoracic junction and the thoracic kyphosis. So this patient was operated previously with a vertebral body resection and replacement, distractable cage, a plate, one level above, one level below. But obviously it did not take care of the cervical kyphosis, because the cervical kyphosis was the result of the hyperkyphosis at the thoracic level. So this patient needed to be treated by straightening out the thoracic spine, the upper thoracic spine, with a long construct. And then we had to revise this cage with a longer plate, a longer cage, a long construct from C2 down to the mid-thoracic level, in order to really correct the mobile thoracic kyphosis, with some minor osteotomies, with some ponte osteotomies. And this allowed to reestablish the thoracic kyphosis, straighten that out, and this helped to solve the cervical kyphosis problem. And it's not so much about solving the kyphosis initially, it's about preventing revisions and preventing failures, because you have not addressed the right pathology. And then you have these cases where you have a spinopelvic driver. So this patient is in cervical kyphosis, but you can obviously see that he's compensating for this overall imbalance. The C2, C7 plumb line was more than 4 centimeters. So you would assume that the patient has a cervical deformity or a cervical kyphosis. But if you look at the whole patient, you will realize that it's a more global problem. The gap score is pathological, and you can see that the patient is missing some lumbar lordosis. And this patient needs a more overall solution, and not only addressing the cervical spine. So this is the first step, how we address cervical deformity. We try to find out who's the driver, or what is the driver of the cervical deformity, and then we are trying to design an individualized and disease-based understanding and strategy for correction. This has been nicely summarized by the ISS group. And here, Chris Ames was the first author, and you can see what I've just mentioned, that the different drivers for the cervical deformity, and then there are some modifiers, whether describing the additional variables contributing to the deformity and to the severity, like the horizontal gaze, or whether the patient had a myelopathy. And this is also important because the modifiers increase the risk of the surgery, obviously. So what you need to really understand that is a full-length standing X-ray. We like to do the EOS, but obviously you can also stack your images. And then you need, you have to assess the neurological situation. And it's always good to have a photograph of these patients for pre-surgery and after surgery, and helping them understand how their posture has changed following the surgery. And it also helps you to assess the gaze of the patient. And this is another paper describing these different drivers. So very nicely, you can see here the cervical deformity case. You can see the driver at the cervical thoracic junction, the driver at the thoracic spine, and the driver at the lower spine, at the lumbar pelvic area. And it's interesting to note that depending, and you can identify the types depending on some of these parameters. So obviously, if the thoracic spine is the driver, these patients have an increased thoracic kyphosis. And I mentioned the relevance of the T1 slope that is increasing with subcervical drivers. I mentioned the plumb line, which is especially pronounced, which is more pronounced in subcervical pathologies than in cervical pathologies. And I also mentioned the compensatory mechanism of the axial spine with C0 to C2 going into hyperlordosis in order to compensate. And this is more pronounced in those patients that have a subcervical driver, because these patients usually have a more pronounced and more complex deformity. So the upper cervical spine has to compensate more than with a classical mid-cervical or cervical driver. So the primary driver is the primary target of your deformity correction surgery, and you have to identify this primary driver. So that's very important. So following your understanding what's the primary driver, here are some principles of the next steps of your surgery. So when I was preparing for that talk, so this is really the first time I'm introducing this acronym, I realized that it would be nice to help some way to help you remember at least our algorithm. And so I came up with that SAM-OI acronym. So S for what segments to correct. So you have the driver. Now you have to identify which segments and how long segments in your driver you would like to correct. Then what approach? A, anterior, posterior, or posterior, anterior in combination. How much correction? So the magnitude of your correction. How much of lordosis do you have to correct in order to reestablish a good sagittal profile? If you know how much you have to correct, you know how aggressive you have to be on the osteotomies. Oh, and finally, which implants to use? Cages, distractible, what kind of screws, whether you have to bridge the cervical-thoracic junction. I will go into detail. So remember SAM-OI. This is really the step-by-step planning and the principles of how we suggest to plan your deformity surgery for the cervical spine. So we have discussed the driver, and the driver leads you directly to the segment that needs to be corrected. So this is done. Approach. So usually it's anterior and posterior approaches. They all have their complication profiles. But in fact, if you are correcting for cervical deformity, you have to do what you need to do in order to correct the cervical deformity. And now let's discuss when you have to go anterior, when you have to go posterior, and when you have to combine the two. So it really depends on the result of your imaging. So you would start with a CT and flexion extension to see whether you have a mobile or whether you have a fixed cervical spine. So here you have a mobile C-spine, and if you have a mobile C-spine, you can come either anterior or posterior alone. Because the spine is flexible, you can, just by your positioning, you can also already gain some lordosis, and then you can use an anterior approach or a posterior approach to correct, and then you would fix. So that's the one approach, the one approach situation, mobile C-spine. Then you have a C-spine which is fixed on the anterior side, either by a ossified posterior ligament, or by fusion surgery that had been done before, or by anterior osteophytes and loss of the cervical disc, autofusion. So if you have a rigid anterior C-spine, but your facets are still open and they're still not ankylosed, you can come from anterior alone, do some anterior reconstruction, some anterior relordosing, and then you would correct and fix. And then you have to decide whether you have to come from posterior in addition in order to strengthen the construct. But for those cases, the correction of the deformity is done by an anterior approach alone. But then you have the cases where you have where the posterior column is fixed due to the facet joints, which are either locked or they are really fused. And then you have a really rigid cervical spine, which is circumferentially rigid. And then you would come from posterior, you would place your screws, you would do the posterior release by doing your posterior osteotomies, either partial joint resections, or you would resect the complete joint. And following the posterior release, you would come from anterior, do the anterior release, put in your cages, do the anterior support, correct with the cages and with the plate. And following that, you would come from posterior. Sometimes you don't even use a plate for anterior to retain the anterior flexibility. And then you would come from posterior, and then you would do some kind of maneuver with your rod, and then you would do the final correction from posterior. So it really comes down how mobile and how rigid the cervical spine is, and this is driving the approaches that you have to take. Okay, now let's talk about, if you come from anterior, how much can you correct? So this is a long ongoing discussion. So obviously, if you're using multiple cages, this is not only giving you a more solid construct, it also it gives you more opportunities for a relordosing. So with every cage that you place, you can gain classically 5 to 8 degrees, but depending on your anterior release and depending on the cage that you are using, with bigger cages, you can even achieve more than the classical 5 or 8 degrees. So multiple cages give you way more possibilities to relordose compared to a corpectomy. Or if you have to go for a corpectomy, then it's good to combine a corpectomy in a hybrid way with a cage. And this is here quantified. The longer your cages, the less possibilities and the less chances for relordosing you have. So if you come from anterior, it's always better to go with multiple interbody cages, and then some tips and tricks to get more than 5 degrees. So here's a case. The posterior elements are not fused. You have anterior fusion. So we came from anterior, and by using multiple cages and the bent plate, at least we could correct. It's not yet a good lordosis, but at least it gives you some idea about that you don't have to come always from posterior, anterior, posterior. An anterior approach alone is often enough to relordose or to correct the kyphosis. However, if you have cases where you have a posterior element is fused, where the facet joints are ankylosed and fixed, then you have to go posterior, anterior, posterior. As in this case, we did first the posterior approach. We placed the pedicle screws. Then we made the posterior release. We came from anterior. We corrected short segment this kyphosis with some cages, and now you can see that we are using cages that are higher than for the classical degen or for the classical anterior decompression. So we are using higher cages, which allow us to give it more lordosis. We have to resect the uncus as well to get an anterior release, and then we can correct this significant kyphosis, and then posterior again putting in the rod and deciding whether you have to extend into the thoracic junction. we never stop at C7. So if we would stop at C7, we go beyond, we go to C1, to T1 or T2, depending on the stress that we expect, but we never stop at C7 because the failure rate is higher with if you stop at C7. And if you have patients where the cervical spine is completely fixed, as for this ankylosing spondylitis patient, which is in severe kyphosis, but here the driver is the cervico-thoracic junction and the thoracic spine due to this ankylosing spondylitis. Here we are performing a T1 osteotomy, a T1 PSO. You can see the PSO area here. You can see the patient after the initial positioning, and this is the patient after relordosing. You can see how we are using the spinal navigation to place the pedicle screws, and we are obviously loosening the Mayfield clamp in order to lift the head and to help with the correction. And this is a case where we are performing the posterior approach alone, only the PSO at T1 for this segmental correction of this significant cervical deformity. So it really depends on what segments are fused and what segments you are aiming to correct. So this is the approach. How much correction do you need? The magnitude of the correction. So this is a very difficult problem because we don't really have, in contrast to the lumbar area or to the lumbar pelvic area, where we have a pretty good understanding. Some are using the Schwab criteria with PI and lumbar lordosis mismatch. Others would use the gap score. We have started to use the gap score, and we are relying more and more on the gap score for the last months. So we are quite new in that field, but we don't have this luxury situation in the cervical spine because the target values, the target angles are not as well defined as for the lumbar pelvian area. So it would be really nice in the context of personalized spine care to better understand what we have to aim for, and artificial intelligence would be very nice to have that to really have a better understanding. We would like to have ways to help us to understand the outcome, but also help us to define the decision how much angles we have to correct, and maybe even what approach and what osteotomy we have to use. But this is still the future. We are still not there, so we have to discuss other ways in order to find out how much we have to correct. We can rely on the classical regression and on the publications that you can see where you see if we correct this and this, then the pain will be reduced by this and this, or the quality of life will be improved. But there's always a big variation. So it's really difficult to give you a good idea about how much you have to correct. In the end, you're correcting and you're aiming for a harmonious overall alignment. So how can we achieve that? Number one, this is, if you are aiming for harmony in your spine, you have to understand what's the driver, and you have to do the EOS or the overall spine, and then you will end up with some kind of measurements. You will aim at normalizing the plumb line of C2 and C7, bring the head back. You will aim at normalizing the T1 slope minus the cervical lordosis. But if the driver is really coming from the lumbar area, then it's more likely that patients will not be as happy if then compared to treating the cervical area alone. So, and if your target parameter, how much do you to correct, is the plumb line, you will have a failure rate of up to 50%. And if your target parameter is T1 slope minus cervical lordosis, your failure rate might be as high as 50 or 60%. especially if it's not a pure cervical deformity, but the deformity has another driver, which is subcervical. So it's very difficult today to have a good understanding of how much you have to correct. And you really have to discuss these cases with some kind of image analysis or with some kind of in an interdisciplinary setting. So this is a paper that has defined other target parameters. It's a very recent paper from last year. So here the C2 slope would be normalized less than 10 degrees, and the plumb line should be less than 4 centimeters. So every group and every publication is trying to define target parameters that help you to understand of how much you have to correct if you're aiming for cervical deformity correction. And this is another paper basically showing that trying to understand what is determining the outcome. When do you fail to restore the plumb line, and when do you fail to restore the T1 slope minus the minus cervical lordosis? And in the end, these are all the patients that are in severe kyphosis. So if you have a patient that is in severe kyphosis, it's way more difficult to really achieve your aim, which might suggest that these patients should be treated earlier when you are still capable, or when you still have a chance to reach your target goals. So if you are asking me how much should I correct, number one, if it's a very severe deformity, you have to accept that you might not be able to reach the perfect correction. Number two, you have to use some plumb lines or some angles or some C2 slopes that you would like to bring into a normal position. And you have to have an overall understanding of the spine. So this is again a patient with some cervical stenosis, some kind of cervical deformity with a mid-cervical kyphosis. Here the driver is the cervical kyphosis. And how are we planning these patients today? So we are planning these patients today in order to understand how much we have to correct, in the same way that we treat these patients for thoracolumbar deformities. We are submitting our images to some kind of computer or to some kind of lab, and we are analyzing and we are simulating the way of how we are planning to correct these patients. So for example, for this patients, we are trying to bring back the C2 plumb line, creating a overall sagittal balance, and therefore we have to we will use some cages, and since it's a mobile cervical spine, we will get away. So we have discussed cages, but we've also discussed a posterior correction alone. So we decided to go posterior since it was a mobile C-spine. We performed multiple osteotomies, SPOs, and we did not perform a cage here. We omitted the cages, and we just placed the customized rod. So we have also started to use customized rods. So we calculate the rod comes from the lab, is sterile, and then we are using the rod as a template, and we are correcting and we are releasing until the template fits to the cervical spine that we are correcting. So we are using basically these customized rods as templates for our correction. And here you can see how we have a plan, and we have the preoperative situation, and we have a plan. So bottom line is, how much should you correct? We are submitting, or we are analyzing these images in a very similar way to the thoracolumbar deformities. We are using customized rods, and we are trying to normalize the C2 plumb line, and then we are and that is really driving our goal, our plan of correction. Here's another example of a complex OPLL, spinal canal stenosis, and this is a case that we have just planned. We have not yet done. It's a case for Friday, and here we are planning to perform a T1 PSO and the decompression, and it will be a long construct from C2 down here. And we have a good understanding from the planning with the PSO T1. We are aiming at 25 degrees correction, and this will, in a way, normalize the deformity, and at the same time will take care of the compression with a laminectomy and posterior fusion. And this is the case of the hyperlordosis, and this is also showing the limits of what I've told you. Our understanding, yes, it might be some kind of instability here, some kind of pannus, but also you can notice the hyperlordosis. Here we did not correct the cervical, the mid-cervical kyphosis. We did a very focal approach in this elderly patient, 75 years or so, C1 to C3. But we have to admit that we had some patients where we have neglected the problems at the mid-cervical and sub-cervical area, and then failed. These patients failed. But certainly, this case, at least this patient needs some kind of focal fusion and focal decompression. And I think this is a good case. This is a good example for the limits. You might not aim at the full correction of the cervical deformity just to normalize the whole sagittal balance. Sometimes you also have to aim for a very focal solution. So following the discussion, how much we have to correct, minor segmental corrections or major segmental corrections, that obviously is the call for the different osteotomies. So these are the osteotomy grades that have been put forward and that are commonly used. Grade 1 to grade 7. So basically, grade 1 is cervical discectomy and partial resection. So you have an anterior release at the level of the discs. You can combine that with a posterior release if you have ankylosed facet joints with a partial resection. Then you have grade 2 where the whole facet joints are resected. From posterior laminectomy plus complete resection of the facet joints can be combined with a removal of the vertebral body. Then you can do a removal of the vertebral body or the cervical disc plus resecting the uncus, and thereby from anterior loosening up also the facet joints. And 5 is an open wedge osteotomy, which you can do sometimes from posterior and then break the spine. It's an open wedge. You might have to close the wedge in a second anterior. But here you are, and then the other one is the PSO. It's the closed wedge where you are basically also shortening the posterior column and shortening the overall length of the cervical spine. And that means that you have to have a good decompression from posterior, and we usually don't do that at C7, but we do that at T1 in order to spare the C7 nerve root. And then you can do the complex reconstructions with the vertebrectomy and 360 releases. But that is, in fact, you can gain 5 degrees here up to 25, 30 degrees here. So I mentioned a small trick. I would like to mention a small trick which we have learned, that for your regular decompressive surgery, you would always resect the posterior ligament to see whether there is still some kind of disc and to remove the osteophytes. But if you do that and if you insert the cage, you usually only elevate. You will not so much relordose. It's usually an elevation. You open up the neuroforaminal stenosis, but if you are aiming at a good lordosis of your segment, you might leave the posterior ligament intact, which then might act as a hinge, and then you open it up. You put in a big cage which you bring into the disc space, the posterior ligament, and obviously you can only do that if the posterior ligament is not compressing. If you have a compressive element with the posterior ligament, obviously you cannot do it. But sometimes you don't have a compression at the level of the disc space, and then you can leave the ligament put in a big cage, and then this helps you to open up with a release. You remove the uncus, and then you can open up the cervical, the disc, and this gives you more degrees of relordosing. So it's important to note that among those that publish and those that do the surgeries and the experts, there is often not a very a high level of agreement. This paper looked at the level of agreement. For example, this case was treated completely in a heterogeneous way among the surgeons. And then there are cases that are quite, where there is a quite good agreement, obviously in that mobile spine. There was a good agreement and in the recommended osteotomies. But if you're wondering what osteotomy should I use, and if you're going into discussion, always be aware that even among the experts, among the deformity experts, there's never a high level of agreement in many cases. So you're not alone if you wonder what kind of approach and what kind of osteotomy you should use. It's more important that you feel familiar with what you do. This is just the add-on of the paper, just describing the deformity type and the level of agreement among the surgeons, and the level of agreement was never very good. So now we have talked about the osteotomies. Let's talk about the implants. I think what you definitely need, you need interbody cages, and we like to use titanium cages. We're not using PEEK cages because the titanium cages are more stable, and it's better to have them on the X-ray to see how much you relordose and how much you gain if you are placing them for multi-segmental reconstructions. Obviously, we use the plates, but sometimes we don't use the plates if we feel that we get an additional relordosing with the final posterior rod. This has especially changed since we are using the customized rods, because when we did it without the customized rods, we did the posterior release, anterior reconstruction using the plate for the lordosis, and then we turned the patient and we put in the rod and adjusted the rod to the screws. But now this has changed. Now we are using customized rods. We are using cobalt chrome rods, so they will not bend. And with the cobalt chrome rods, we are then putting some cantilever techniques, and this by not using the plate in the second step, we can still get some relordosis. We then have to check for the position of the cages that they don't open up too much. But it's very important. If you want to have the plate in, you cannot correct from posterior. Sorry. Then we are obviously using the titanium, the destructible cages for corporectomies. And I think pedicle screws have really become standard today. So I think for good deformity corrections, it's more easier with pedicle screws, and I will show you how it has become safe, than with lateral mass screws. I mentioned the cobalt chrome customized rods. You have to think about transitional rods if you're going down to T1 or T3. We like to use 4-rod solutions with dominoes if we cross the PSO side, like T1 PSOs, and obviously long constructs, and we use crosslinks even in the cervical space. So the pedicle screws have a better pull-out force. So basically, in overall rule of thumb, one pedicle screw is as strong as 2 lateral mass screws. If you use pedicle screws only, they are also in line. So and then you can angle the screws following the pedicle, which gives you, and you have a more oblique trajectory of the screw, which is also biomechanically superior to the lateral mass screws. So if you really want to put force on the screws, you need pedicle screws. Problem, however, is, and then if you have the pedicle screws, you can persuade, you can lift the Mayfield to relordose, you can use a cantilever maneuver with the cobalt chrome rod, and you can compress without pulling out the screws. So pedicle screws are the new standard. However, usually they are associated with a higher risk for neurovascular injury. So what has changed? What has changed is the use of navigation. So obviously, many of you or all of you are using navigation, and we have shown in multiple publications that you can achieve a very high accuracy also in the cervical spine. Accuracy of the screws is up to 90%, very similar to the thoracic spine, a little bit better in the lumbar spine, but it works very, very well. And you can pimp this accuracy if you are increasing the quality of your intraoperative imaging. So this is with a 3D fluoro, 90%, and this is with an intraoperative CT. So if you have the intraoperative CT, you can place the perfect pedicle screws with a 95% accuracy. This has made placement of pedicle screws way more safer. With some experience, you have to revise less. You can apply it to all the segments of the mobile spine, and you can optimize, and it really is only 20 minutes more, but it really pays back to place pedicle screws in all of the segments and make pedicle screws your new standard. So now you are asking 95% accuracy. How are we doing it? Definitely, you should not push and not press with pressure tools on the pedicle and on the area where you perforate the cortex. What we are doing is we are using K-wire based techniques. So we have a screw, we have the cannula for the electric drill. We are drilling the cannula is navigated. Then we are drilling into the pedicle. We are placing the K-wire. We are placing K-wires in all of the pedicles. And then we are controlling the position of the K-wire. And only if the K-wire is in the correct position, we are then placing the screws. Again, you can use navigation or you can do it freehand, because once the K-wire with 30 millimeters or 25 millimeters is in the vertebral body, and this has been checked, then you can place the cannulated screws. It's a big discussion because many companies think they will get away without cannulated screws, but we really advocate using K-wires for the placement of your pedicle screws, which becomes important if you're going for percutaneous system in the next step. So this is how we do it. We place the reference array at the distal spinous process, which is C7, C2. In your first step, usually you have a fixed cervical spine, so it's not an unstable situation, so we are very relaxed. So we are not referencing each vertebral body. We reference with one intraoperative image acquisition, which is usually a CT. Then we are deciding whether we have to have additional skin incisions to place the screws following the trajectory of the pedicles. But usually you have big openings, so you will get away with additional incisions. We avoid pressure tools. We have a navigated drill cannula. Then we place the K-wires, and then we place the screws. So this is our setup. So we have an intraoperative CT. We have the Dyna CT, and we have a robotic Dyna CT in a different ORs that we are using. And with all these systems, we are more than 95% accuracy. And here you can judge the quality of the imaging. And this is what I mentioned with the customized rods. We are customizing today also the cervical rods. It's planning. The problem is that the lab is still not adjusting for compensation because the data is not available. But at least you can use, similar to the thoracolumbar deformities, we are now customizing our rods and planning our rods for the cervical spine. So which implants to use? Finished. It's clear. SEM, OI, clear cut. So now we have 5 minutes left. I will discuss about outcomes. You would like to have some kind of prediction of the outcome. As for this cervical spine herniation disc surgery, so this group came up with an algorithm. You can predict the outcome. Here the outcome is predicted for the reoperation for infection. Here the outcome is predicted for quality of life or for pain. But this is not available for deformities. An interesting observation is that today, even in expert hands, the variability of your outcome is huge. This is the pain readout. So we have patients that are okay, we have patients that are outperforming the okay patients, and we have patients that are underperforming. There are multiple studies trying to understand why this group failed and why this group is hyperperforming, but there is not a good understanding. And the same is true for the neurological outcome for the JOA. Some are good, some are better than expected, some are doing worse than expected. So what is driving the outcome? This multivariate analysis has shown, number one, the surgical strategy, the type of deformity. If it's a cervical deformity, you have a good chance for a good outcome. If it's a subcervical deformity, if it's becoming more complex and the deformity is more pronounced, it's difficult to have a good outcome. The complication profile is important. Do you have a CSF leak? Do you have obviously some aggravation of your myelopathy? This is driving the outcome. And in the end, also whether you are achieving the optimal radiographic result, if you are successfully reestablishing the cervical lordosis. And this is really showing that patients improve to 80% due to a reestablishment of the radiographic factors. And this brings me back to the discussion whether it's important to normalize this profile of the cervical spine. If you are aiming for a good outcome, your good outcome, pain and neurology, mainly pain and revision rates, is determined on the biomechanics, on the radiograph, and only 20% whether the patient is improving neurology-wise. So it's really important not only to take care of the spinal cord, but also to aim for a good result in terms of biomechanics and alignment. And in the end, the incidence of poor outcome is 70%. And usually those patients where you are failing to have a good radiographic outcome, or where you are injuring the spinal cord. These are the patients that are not doing so well. So in conclusion, cervical deformity in most cases is cervical kyphosis, and it either comes with or without a cervical myelopathy. And there are only a few cases, like the hyperlordosis syndrome at the axial spine, where you have problems due to hyperlordosis. You always have to understand, or you have to learn to understand cervical deformity in the context of the global sagittal alignment. Often cervical deformity is the result of misalignment in the thoracolumbar area. You have to measure the angles that I've shown you, and this will help you to understand how severe is my deformity and what is the driver, what's the nature. We have talked about the surgical goals. It's not only about decompressing the spinal cord, but also you should try to reestablish the alignment as much as possible. I've shown you this SAM-OI algorithms, the different principles for the surgery. You have to understand that it's still complex surgery, and up to 20% of your patients will not be happy. And they objectively not only will complain of a bit pain, but they will really have an unfavorable outcome, and we don't really understand what the reasons are. And but we have to keep in mind that if somebody fails, the patient will most likely fail because the radiographic result is suboptimal. So I thank you really for having me, and I apologize for being too long, 70 minutes, but I hope that this will provide some basis for further discussion. Thank you so much for having me.
Thank you very much for you. There is no time limit. Thank you for a spectacular lecture. We're listening, mesmerized as always. And I think the audience was also mesmerized because I don't see many questions. There is only one. So I will use this opportunity to ask my question. So neuromonitoring, you mentioned, but like since the cervical spine is mobile, to what extent do you rely on neuromonitoring? And do you have in your practice the cases that it has become more hindering than helpful? And how do you decrease the, besides using high-speed drills you already mentioned, what are your tips and tricks?
No, so let's start. I haven't understood the second question, but the first question about the neural monitoring. So we are really heavily relying on neural monitoring. I think there are two neurological complications that are really keeping us awake. Number one is injury to the spinal cord. An injury to the spinal cord is not only when you are correcting. Injury to the spinal cord might happen when you are positioning the patient or when you are turning the patient, or it might be affected by low blood pressure. So neurophysiology is very helpful in detecting when you have problems during positioning or when the blood pressure is low. So that's the first checklist to see what the blood pressure is when we see changes in MEPs and SEPs. Obviously, we are also measuring electrophysiology when we are performing the correction. And I still feel sometimes you get false readings, but I accept some false readings for the cases where it's for the true positives changes. So if there is a change and you really are compressing, especially if you're doing T1 PSOs and you see the dural sac crumbling and the bone and the osteotomy is closing, and then it's really helpful to see whether you have some impingement of the spinal cord. And I think neurophysiology is really helpful. So it never really hindered me. If I check everything and there is nothing, and if I loosen it up again and it doesn't really change, I was glad enough that often it turned out to be a false positive reading. But sometimes the reading was true, but I didn't find the reason for that. And the second complication where neurophysiology is not so helpful is radicular injury, especially the C5 nerve root. So what I really hate most is you have done a beautiful surgery, the spinal cord survived everything, and then the patient has a C5 palsy. This is really super frustrating. And we are trying to use electrophysiology to better understand the nature of C5. And here, obviously, same is true for C6. Here, electrophysiology is not so helpful because we are still in the experimental stage and understanding the role of electrophysiology and the role of the nature of radicular damage.
Thank you very much. You answered my question perfectly. I will start reading the chat. We have the first question from Suleiman Akaya. Hello, doctor. Thank you for a great lecture. When we do anterior discectomy and cage fusion for kyphosis, inserting big cages for gaining lordosis, patient suffers a lot of post-operative neck pain for a month. Do you have any recommendations for these patients?
Oh, okay. So I think if you are doing regular disc surgery or if you are doing an anterior decompression for a regular spinal canal stenosis, I always insert a 5mm cage, especially if the posterior elements are mobile, because if it's too big, if you are using indirect opening of neuroforaminal stenosis, then as you say, you are risking stress on the posterior elements, which give the patient neck pain. So for these cases, I always use a low cage, 5mm or a maximum 6mm in younger patients that need fusion and do not get away with arthroplasty. But here we are performing a deformity correction, and the patient has multi-level fusions, and there you in a way accept neck pain for some time, which then resolves. And if you are going posterior, anterior, posterior, then there are other reasons why the patients have neck pain. I really think that if you do the posterior approaches extensively, I mean, we have not talked about it. Another complication is by approach-associated neck pain. I think the neck pain by the posterior approach is way bigger than the neck pain from the anterior approach because you have relordosed a bit, yeah. So what we do then is we are trying to tape the shoulders back with some bandage, and trying to release the pressure on the wound and on the muscle. But I think it's a big issue, back pain from the facet joint, if you're doing minor surgeries, but it's not such a big pain given the complexity of the surgery if you're going for deformities.
Thank you. We have a comment from Timurhan Aksoy. Many thanks for the presentation, Professor. It was really nice to learn from you again. Next is Ayhan Kanat. Many thanks for this nice presentation. What do you think about Atul Göle policy in the treatment of craniocervical area? This author managed the some pathology in this area, such as Chiari malformation, cervical syringomyelia, cervical myelopathy by C1, C2 fixation.
Yeah, so Arthur is a very good friend, and I like to discuss with him. But I think it's a controversial topic. I think that he really contributed significantly to the management and the understanding of C1, C2 pathologies. I think it's always important to stress that it's not only the harms, it's the Harms-Goel technique that we are using for C1, C2. So that only to mention and to acknowledge his contributions. But what his message is that all these pathologies around the craniocervical junction, Chiari and syringomelia, are always, or in many cases, more than 90% in the majority, are the result of a C1, C2 instability. And I think there we have the controversy. What I learned from him is to always assess whether there is some kind of instability at C1, C2, and I can confirm that some C1, C2 pathologies are the result of a C1, C2 instability. But I would not go as far to say that all the pathologies or the majority of the pathologies are the result of a C1, C2 instability. Here, I'm not yet convinced by him, and we have some controversy. But saying that, I also have to say that I have learned really the understanding of the non-obvious instability. I think was very invaluable or very valuable, what I've learned from him. And but I would not fuse everybody. I would fuse those that have that hyperlordosis because there is obviously a C1, C2 instability. But I'm not sure whether we have really addressed the full range of the problem in that specific case that you are referring to.
Thank you very much. And smoking linked with high risk of hardware failure, does it influence your decision making in a clinical setting?
No, both of my parents, both Hungarians, have smoked a lot, together 100 cigarettes per day until they died of it. And therefore, I really have a high tolerance and a good understanding for patients that are smoking. And I think in the countries where many of the listeners are coming from, it's a very similar situation. So I think it's a little bit, how should I say, it's difficult, and sometimes it's a little bit of also arrogant to tell people to stop smoking, and before that you will not treat them. I think it's very good to understand that risk factor is one, that smoking is a risk factor for hardware failure, but I would not go this far to tell people that they have to quit smoking, because as soon as they are happy with the surgery, they will start again. So I'm rather realistic and not pushing too much pressure, not putting too much pressure on my patients, trying to understand their shortcomings.
Thank you for your honest response. And we have one more from Supriyo Konar. It was a pleasure attending this meeting and hear you speak so briefly on this topic. As a medical student from India who really interested in neurosurgery and neuroscience behind it, I really hope to one day work and learn in person under your wing, Dr. Vajkoczy. Thank you so much for your valuable time, sir.
Thank you very much.
And I think I will ask Dr. Hassan, do you have any comments or questions?
I would like to thank the professor for this very detailed and fully comprehensive lecture. I will be happy if I get some detailed information let's say about corpectomy or pedicle subtraction osteotomy on the as I saw, you did the T2 pedicle subtraction osteotomy, and it was very good indeed. What is the most cranial level other than C7? Can it be done in the upper cervical vertebra, for example, C6, C5, or is the most cranial vertebra for subtraction osteotomies or wedge osteotomies is C7?
I mean, the drawback of PSOs is that you are obviously closing the neuroforamen and putting stress on the nerve roots, and even the PSO at T1 can be problematic because the nerve root C8, as you all know, is important for the hands. I'm not doing C7 because I'm fearing C7 nerve root injury, and my friend Ibrahim Obaid has said there's not one level in the cervical spine where he has not performed an osteotomy in his life. So you should ask him. I never went more cranial than T1 or T2.
Thank you so much. And it was a good night for us. It was a good lecture. And I want to thank everyone who joined us today from all over the world. And I hope to see the professor in real life, like you, Madana, someday.
I think our societies, German and Turkish, are working on a joint meeting in Turkey. So I hope to see you next year in the beginning of April, I think it is.
I will be very happy. Thank you.
Thank you very much, Professor, and thank you for the audience, your contributions. Thank you.
Thank you for the invitation. It was really a pleasure. And you forced me to structure my thoughts, and this presentation was really the first time I gave it, so I'm really happy that you liked it. Thank you so much.
Thank you.
Thank you.